For early disease, we divide our treatment based on muscle invasive or non-muscle invasive disease. With non-muscle invasive disease, we have BCG treatment that still remains the mainstay, but patients that have non-BCG responsive disease or BCG refractory disease, we now have a few options. Radical cystectomy is what we've relied on, but then pembrolizumab, gene therapy, ongoing trials for pretzel to deliver local treatment. But when it comes to muscle-invasive disease, that is where, as medical oncologists, we get more involved. And recently, we've also seen NIAGARA trial in this space. Joaquim, can you start us here? Walk us through your treatment paradigm for early muscle-invasive bladder cancer.
Yeah, so the first thing, and it's very important that the term muscle-invasive bladder cancer is telling us that the urologists have obtained muscle and the muscle is invaded. And this is something that that differentiates non-muscle invasive versus muscle invasive. The treatment is completely different. Here is chemotherapy, immunotherapy, and aggressive surgery, the backbone of treatment. In patients with muscle-invasive bladder cancer, after obviously staging, excluding metastatic disease, you don't need to get a PET CT that sometimes even people is doing, but yeah, maybe a good scans or MRIs is enough. Then we have patients who are two differentiations, patients who are cystectomy eligible, meaning there are no comorbidities that prevent them to go through a high-level surgery. Removing a bladder is not a banal thing, right? And then patients who are cisplatin ineligible, or maybe they decline a cystectomy because they are you are losing your sexual potency with a cystectomy, you have urinary issues, body image change because you need to wear a bag or other type of urinary diversions. So let's focus on the patients who are cystectomy eligible. Here, we have two different groups of patients. Those that the renal function is adequate to receive full dose cisplatin-based therapies. And cisplatin-based therapies is cisgem, durvalumab. So the criteria of cisplatin eligible is mainly based on good performance status and creatinine clearance more than 60 ml per minute. This is defined by prior trials. In the NIAGARA trial, patients with creatinine clearance receiving cisplatin, gemcitabine, durvalumab, we had patients having creatinine clearance more than 60, but there was a subgroup of patients that still having creatinine clearance in between 40 and 60, they were allowed to receive split dose cisplatin gemcitabine. And this is an important point. So, and this is for the first time in a clinical trial where the split dose of cisplatin gemcitabine, and meaning the split dose means that cisplatin, instead of being given one day at 70 milligrams per meter square, is given day 1 and day 8 at a 35 milligrams per meter square. We have presently 3 options: the standard cisgem, the dose ends and back, or the new regimen, including immunotherapy with durvalumab. This is a space that we call perioperative. And presently in the perioperative, giving neoadjuvant chemotherapy, meaning chemotherapy before the surgery, is the standard of care. It has the highest level of evidence based on meta-analysis and randomized trials, providing a survival benefit. And at the time that these neoadjuvant trials were done, it was using cisgem or regular MBAC. We didn't involve the adjuvant part of treatment, meaning after cystectomy. The benefit was seen in patients receiving just neoadjuvant chemotherapy followed by surgery because we didn't have adequate therapies providing benefit in the postoperative setting. Now the landscape has changed, and because with the trial, the NIAGARA trial, we have seen that we are starting with neoadjuvant chemotherapy, meaning before the surgery, and we are adding immunotherapy with durvalumab. Then we proceed to cystectomy, independent of the surgical pathology, and this is something that we discuss all the time. Then you give durvalumab as adjuvant to complete a year of treatment, meaning eight cycles of durvalumab. That's the new NIAGARA trial, and for the first time in this trial, where this strategy, cisgem durvalumab cystectomy followed by durvalumab, was compared with the standard cisgem followed by cystectomy with no adjuvant therapy. This trial was designed in 2016, and at that time, adjuvant therapy was not standard. For the first time, we saw a survival benefit when giving cis-gem durvalumab versus cis-gem alone. And as mentioned, cis-gem durvalumab was followed by adjuvant durvalumab. So we have trials showing that the dose dense and back is also an option, likely in young patients. Some people have said maybe dose dense and back is enough, followed by adjuvant nivolumab, but we don't have trials to answer that. So presently, obviously in places where durvalumab is available, still it has not been approved by FDA. So the results have been published in the New England Journal. Nowadays, we could say we have as a first option cis-gem durvalumab, cystectomy followed by durvalumab, or we have platinum-based, that could be cis-gem or dose dense and back, followed by cystectomy. After cystectomy, we have agents approved in the adjuvant setting. In the adjuvant setting, the benefit of giving, if the patient has not received neoadjuvant chemotherapy, giving a platinum-based chemotherapy, there is a meta-analysis showing a survival benefit. There is no randomized trials, it's only a meta-analysis. In this second-line setting, in patients that have not received platinum-based therapy or that have received neoadjuvant cisplatin-based therapy, but in the surgical pathology still there is more than T2, there is margin positive, there is lymph nodes, then we have these trials testing the benefit of giving adjuvant immunotherapy, nivolumab, pembrolizumab, or atezolizumab in these high-risk patients. Patients that receive neoadjuvant and fail at some point, or patients having poor renal function, not able to receive cisplatin, didn't receive neoadjuvant chemotherapy. The drug is presently approved by FDA is nivolumab. Nivolumab provides benefit in terms of disease-free survival. Despite 4 years of follow-up, and this trial compared adjuvant nivolumab versus just observation, we haven't seen a survival benefit. There is a trend in survival benefit, and mainly this trend is seen in patients that have PD-L1 positivity. And for example, in Europe, nivolumab is only approved in patients who are PD-L1 positive. Here in the US, we are lucky we can give that in all comers without the need to test for PD-L1. The second drug that has shown the same benefit in disease-free survival is pembrolizumab. This was an alliance trial. The survival still is short. We cannot compare these trials because the design were completely different. So for example, nivolumab was randomized to blinded treatment. Patients didn't know if they were receiving nivolumab or placebo. For the others, those were open trials, meaning pembro was treatment versus observation. And at that time, nivolumab became approved and there was a lot of crossover. The benefit for pembro is there and has been recently published in the New England. But still the survival, no benefit in survival, so we are waiting long-term follow-up of this trial. And the third drug, atezolizumab, I was a PI of this, and unfortunately, this trial was negative. There has been subsequent studies analyzing the role of ctDNA in that space, and we published that in Nature. Now we have completed the accrual in a trial that is named IMvigor011, where patients with positive ctDNA being randomized to adjuvant atezolizumab versus just observation, because the benefit in this trial of atezolizumab was seen in patients that had ctDNA positivity. So moving to the cis-ineligible, as mentioned, these patients are not candidates to receive cisplatin. In the NIAGARA trial, patients with this GFR of between 40 and 60 ml per minute were allowed to receive a split dose. In these patients, after cystectomy, if platinum is not given, nivolumab or pembrolizumab are playing a role. These patients can receive this treatment. Concerns regarding upper tract. We're talking about bladder cancer. Upper tract seems to be a different, for example, the benefit was not great in patients receiving immunotherapy, and there is the POUT trial also with no survival benefit that even using carboplatinum adjuvant and cisplatin seems to provide us PFS, but that's another topic for the future. The second group of patients is those that are cis-ineligible or declining cystectomy. In these patients, the standard of care is concurrent chemotherapy and radiation therapy. Here, the trials using neoadjuvant chemotherapy, there was a small trial that was negative. And so people think, well, why not to give neoadjuvant chemotherapy in these patients receiving chemoradiation therapy? And there are people that out of guidelines, they still believe, well, let's give neoadjuvant. And then we are testing how the chemotherapy works. and selecting candidates for bladder preservation. This is something that I discuss with the patient. If you see that you have a very good response, there is minimal disease after the neoadjuvant, you are the candidate for chemoradiation therapy. No, not the guys that are not responding or having bulky disease. But chemoradiation therapy in selected patients, there is no prospective randomized data that can provide the same benefit as neoadjuvant chemotherapy and surgery. I think that's the landscape of treatment in bladder cancer nowadays.
Wow, there's a lot to unpack here, Joaquim. Thanks so much for walking us through that. Some of the important points you reiterated are that carboplatin is inferior, so we have to rely on cisplatin-based therapy in the entire localized or locally advanced setting of bladder cancer. Additionally, adjuvant nivolumab is approved in high-risk settings, and that's what we have been using. However, given the NIAGARA compelling results, these are impressive enough that one should start adopting it once this becomes FDA approved. We are used to utilizing this approach in triple-negative breast cancer
Yep.
and also in non-small cell lung cancer.